Hello class, this is Dr. Turpin. I'm going to review a couple of diseases in both chapter 58 and 59 on videotape. This will be kind of a minor lecture, but make sure that you really do go and review those chapters for these four diseases, particularly looking at nursing care and interventions. I'm going to try to give you an overview of some of the typical things that go on with assessment, diagnosis, and treatment, but try to do a little further review than this on your own since this is short. Just make sure that you review and kind of understand the structure and function of the liver. I know that you had that in Dr. Bernard's class last semester. Of course, we do know that alcohol does cause problems with the liver that do and can lead to cirrhosis. Also, excess intake of a fatty diet can cause fatty liver that can lead to liver disease. Some of the complications of cirrhosis can be all these that are listed. One of the most common ones that we typically see is ascites, and some neurological changes such as confusion related to hepatic encephalopathy and esophageal varices, which I'm going to review and show you a little detail on. And then they can also develop hepatorenal syndrome, where they have complications of the liver that lead to renal disease. These are the broad range of all kinds of clinical manifestations in which cirrhosis, you can see patients with all these kinds of issues. They can have, as I said, esophageal varices. They can have splenomegaly from the backup of the portal vein, meaning an enlarged spleen. You can see the picture there of ascites. The lower abdomen has got a fluid buildup in it. They also can develop jaundice, where you'll see that in the sclera of the eye, but also in end-stage problems with liver disease, you will see that, jaundice, yellow condition of the skin all over. They tend to have some skin itching and issues, swollen ankles, red palms, and can become very anemic and develop leukopenia and thrombocytopenia as well because of hematological issues that are being caused from poor liver function. Esophageal varices that are caused by cirrhosis are one key indication. You see the typical alcoholic that has cirrhosis that will show up at the emergency room and is coughing up or vomiting up blood. And I'm going to show you a picture of that so that you can see that in more detail. But pretty much what happens is there's so much compression of the portal vein in the liver that it backs up blood and causes portal hypertension, and also makes the veins that are in the esophagus bulge, and therefore makes them more likely to bleed with any kind of irritation in the tissue of the esophagus. I provided you a YouTube here just to kind of look at an actual video that shows how the esophageal varices bleed. And this picture on the right just kind of explains when you do have this kind of a bleed, a person can literally bleed out and be, hypovolemic and unstable because of low hemoglobin hematocrit. And so this picture just kind of shows the typical way that they would put down a specific lavage tube and inflate a balloon in both the esophageal area and the gastric area to try to compress those veins so that they slow the bleeding, and then be able to suction out, and try to apply pressure internally to stop the bleeding. So cirrhosis of the liver occurs in 1 in 10 Americans, so it's a fairly common disease. And it is extensive, irreversible scarring of the liver that has developed progressively and over a prolonged course, and can move to end-stage liver disease over many years. Common causes that you see from alcohol consumption, also from viral hepatitis. Hepatitis C is the second most common cause of cirrhosis in the United States. There are also autoimmune hepatitis, that's a reaction where the liver becomes inflamed because of autoimmune problems. I mentioned already fatty liver that occurs with obesity. There are certain drugs and chemicals that can be toxic to the liver that can cause damage in the scarring as well. Gallbladder disease can cause blockages, and that can also cause pressure back on the liver. There are also metabolic and genetic causes that are not well understood. And then cardiovascular disease in general, as we've talked about with atherosclerosis, can cause problems with circulation to a large organ like the liver that decreases the circulation and then causes destruction to the liver. So diagnostics for liver disease, you're going to assess the patient for fatigue, a significant weight loss, GI symptoms such as anorexia and vomiting. They often will have abdominal pain and liver tenderness, but a lot of times those are ignored by the patient, and they just kind of put it off, thinking it's something else. In terms of, this is kind of the short list of labs. Of course, you're going to have elevated liver enzymes, which the first list there indicates. You can have elevated serum and urine bilirubin levels, elevated serum protein and albumin, elevated serum ammonia you often see with encephalopathy, because that is what is driving the mental status changes with encephalopathy. And because of the way the hematological changes I mentioned earlier, they can also have prolonged PT and INR, meaning it takes a lot longer for their blood to clot, and they can have blood loss very easily, as you saw with the esophageal varices. Other diagnostics that can be done to determine cirrhosis: abdominal x-rays are pretty good at identifying this, CTs, MRIs, ultrasounds. Liver biopsy can be done, but it's kind of high risk because of the chance of it causing bleeding internally. And then other types of tests can be done, such as EGDs and ERCPs, and it allows for biopsy. And if there's stones in the biliary system that is causing the problem in the liver, then those can potentially be removed at the same time. This is just a good concept map. I would use this for studying, just so that you kind of understand the overall nursing care that we should be rendering, versus having all this on slides. I thought this was a good way to display this for you guys to study using this, and this is a snapshot of a concept map that is in your book. Now on to hepatitis. Of course, there are different types of viral hepatitis. There's A, B, C, D, and E. A, of course, we know is enteric. That's why we always have to have the contact enteric precautions, along with C. difficile. Hepatitis A is one of those, just like that would be spread through enteric means. B, C, and D are all bloodborne diseases, so it requires blood-to-blood contact. And a lot of those, of course, have been transmitted through things like IV drug needle sharing or accidental, needle stick injuries and things like that. Also, hepatitis E, which we don't have a whole lot in this country, is really a waterborne disease that infects people, and it's in a lot of on the Indian continent and some Asian areas is where you see that more often. Each one of these will have a different onset depending on and an incubation period before onset occurs. And so someone can be semi-contagious because they have been exposed and not know it before developing disease. There is I did include a table with laboratory tests, and we'll talk a little bit more about the plan for care and how to manage the patient with hepatitis. In terms of physical assessment, you want to assess whether the patient has abdominal pain. If you're seeing the changes in skin or sclera, which we call icterus, with the jaundice in the color to the sclera. Other clinical manifestations that you may see is arthralgia, joint pain, or muscle pain, myalgia. These patients may experience diarrhea or constipation. They may see changes in color of their urine or stool that mimic the bilirubin color. So it's always important to ask them specifically about those colors or observe the color of their urine when you're obtaining a specimen. They may have fever, lethargy, malaise, nausea, vomiting, and pruritus is very common with itching, very itchy skin. Of course, with diagnostics, it goes without saying that with liver damage that's caused, particularly with hepatitis A, B, and C, you're going to see elevated liver enzymes. You may see elevated bilirubin levels with jaundice when it's present. For Hep A, you'll have hepatitis antibodies for A. If it is Hep B, you may see antigen antibody positive, and then a viral load that is determined on blood test. And then for Hep C, the test that we use is the ELISA test. And then if they're trying to determine the level of liver damage that has occurred from hepatitis, they may again do a liver biopsy with the idea that they have to be careful with that procedure, as I mentioned before, because of potential for bleeding. Now, these are just a couple of ethical questions to consider. Should a patient with alcoholic cirrhosis be a candidate for liver transplantation? That's been a concern, and I think, people are thinking, well, is that really fair? Someone has caused the damage significant to their liver, where there may be somebody else that had a liver disease that wasn't related to an action on their part. And then another question is, should government funds be used in the care of patients with cirrhosis who continue to consume alcohol? So those are some good things to, consider and talk about with the team if those things are in place in the hospital setting. This is just a list of drug therapy. I would review this, just kind of be aware of several of the drugs that can be used for both hepatitis B and C. You may see those on tests later. Main nursing interventions are going to be, the key thing is the patient needs to rest until the liver inflammation is resolving. So you don't want to overstress them. You want to do ADLs gradually. You want to support nutrition. Small frequent meals that are high in carbs and calories, but only moderate in fat and protein. And really try to see what their food preferences are. They are always going to be on supplemental vitamins as well. And of course, we want to prevent spread of infection in the community and in the hospital.